Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Gurevich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
I am so excited about today's episode because it is a topic that I have unlimited questions about, and it has so much confusion.
I couldn't agree more.
So we're really lucky to have Dr. Kapadia introduce SIFO, which is something that she understands better than any other physician I know. And she's just going to break it down for us and explain what we're looking at, what we're talking about, how it presents. And then we're going to ask 1,000 questions because both me and Dr. Sand are thoroughly confused by this topic.
Yes, we are.
Okay, sounds good. So should we just start with some definitions and kind of go from there, and then you guys can jump in with questions?
Please.
Yeah, that sounds great.
Okay. So the way I like to explain SIFO is a lot of people know about SIBO these days in our world and even in conventional medicine. And we think about that, of course, as an excessive number of bacterial organisms in the small intestine. So the way I like to think about SIFO is it's similar, but it's an excessive number of fungal organisms in the small intestine. So like SIBO, as far as fungus goes and yeast-related organisms, it's normal to have some quantity of those organisms, mostly in the large intestine. But for various reasons, some similar to SIBO and some different, some people develop an excessive number of these fungal organisms in the small intestine. And so it can cause many of the same symptoms that we see with SIBO, which we typically think of as irritable bowel syndrome type symptoms. But there's also many other conditions that potentially can be affected. And so most of us know those symptoms, gas, bloating. In the studies, it was more diarrhea with SIFO, but clinically we see a significant number of patients with constipation also have fungal overgrowth. And it can also predispose to becoming sensitized to food allergies as well as environmental allergies. There are also links to things like histamine issues and potentially MCAS as far as things that can kind of cascade down the line and be related to fungal overgrowth.
MCAS, can somebody define it?
So mast cell activation syndrome, there's formal definitions and there's sort of ways that I explain it to patients. And sometimes I'll broadly just say histamine related disorders, but mast cells are cells that are found throughout our body, definitely in the GI tract, but in many other organ systems as well. And the way I explain it is that for various reasons, a lot of patients these days have sort of hyperreactive mast cells, and mast cells contain histamine and many other chemical mediators. So if those cells are hyperreactive, you're going to manifest all sorts of symptoms that can mimic allergy and several other conditions that can be confusing if you don't realize it's from this hyperactivation of mast cells.
So when you see it in clinic, is it usually an acute diagnosis? Is it a chronic diagnosis? Could it be both?
It's almost always chronic, typically because we're seeing patients that have had digestive issues or systemic issues for a really long time. I would say occasionally I'll have someone present sooner after, let's say, a course of antibiotics when they decided they started to have a lot of different symptoms. But typically they've been trying various things on their own for a while, or they just didn't really know what to try. So by the time we see them, it's generally been going on for at least a year, if not years or decades.
I'm really curious about diagnosis and then how often you see it go along with things like SIBO or other intestinal disorders and how you differentiate.
Right. So the way I like to explain to patients who have potentially these gut imbalances is I say something to the effect that we all have some mix of bacteria, yeast, and often protozoa in our GI tract. And as far as the microbial component of what's causing their symptoms and imbalance, there's usually a combination, often of all three, that are out of balance. I mean, occasionally we'll have someone with just SIBO, just SIFO, or just Protozoa, but it's much more common that I see that they have some combination of the three. And the problem is clinically, it can look the same. Right. They all present with similar symptoms because they're affecting the microbiome in negative ways, and they can be working together in biofilms and other things. So it's a challenge clinically to know. That being said, we have a lot of patients where they've been treated for SIBO already. So we know that if they still have significant symptoms, they've been treated for SIBO, their breath test has normalized, but they still have symptoms, at least we've got good testing for SIBO where we can say, okay, that's kind of been well managed. What else is there? And so I'll often at that point test for Protozoa with stool testing, which we can talk about. And I'll potentially, I almost always do lab covered testing for SIFO, which we'll talk about, and sometimes out of pocket testing, depending on how much objective data we want before doing trials of treatment.
So my question is, when I think about fungus and fungus in the body, I think about like yeast infections or toenail fungus or like tinea on the chest.
Right.
Do they have to have these symptoms to make the assumption that they have SIFO?
No, I just had a patient last week who has tinea versicolor, and she was under the impression because she's had this since she was a kid, she definitely has fungal overgrowth in the GI tract. And I have not seen any evidence to support that. I think there are probably people who genetically have a predisposition to having trouble controlling fungal organisms affecting various parts of the body, but by no means do you have to have the other symptoms to manifest a GI overgrowth. I would say my patients who have a history of recurrent vaginal candidiasis do often have a fungal organism issue in the GI tract as well. But with skin manifestations or toenail manifestations, I have not seen a particular correlation with these external sort of manifestations of trouble with controlling yeast and fungus with the internal issues, particularly with toenail fungus. You know, lots of people who have jobs where their feet get moist and are in boots all day, they by no means necessarily have any kind of other internal issue. It's really sort of environmental factors that are predisposing them to that issue.
And I get asked a lot by my patients who have a thick white coat on their tongue, not necessarily thrush. You know, and in Chinese medicine, that means something, but it's not necessarily thrush. It's just the thick white coating.
Right.
What are your thoughts on that?
I sort of learning from all of you as far as in the Chinese medicine perspective, I'd love to hear a little bit more about what you have to say. But to me, it just means they're having some form of dysbiosis, digestive imbalance. It doesn't necessarily mean there's a yeast issue. It could be food allergy. It could be that mix of dysbiosis we talked about. It could be that they're just eating a lot of junk. So I don't typically see that as a particular, it could be part of a fungal overgrowth because that's part of dysbiosis in general. But
it's
typically
non-specific.
It's non-specific unless you look at it under a microscope, if it's scrapable, if you see it on the mucosa and not just the tongue, that would lean more towards it could be like a actual fungal issue.
Right. Got it.
So when do you start thinking about it?
So typically for any patients with digestive issues, a lot of skin issues, histamine intolerance, brain fog, potentially joint pain. So a lot of the various systemic and digestive symptoms we see, particularly if they have any digestive issues, I'll pretty much always run at least, again, those lab covered tests, so I always start with Candida antibodies and immune complex, Candida immune complex, which you can get through Quest or LabCorp.
And that's
serum.
Those are serum.
And that's IgA, IgM, IgG?
So I check for, yes. So IgA, IgM, IgG for Candida antibodies, and then a Candida immune complex. And I always tell patients, this is not diagnostic of a problem. Many people have antibodies, but I sort of see it like when we do IgG food testing, where there's sort of a cutoff of everyone is going to have IgG antibodies to a lot of things that they're exposed to just as part of the immune response. But if it's above the lab cutoff of what they say is normal, I explain it as your body might be having difficulty with the relationship with yeast and fungal organisms, particularly in the GI tract. And it may be worth empiric trial of treatment, especially if they have these symptoms that we know correlate with IBS, et cetera. Or we could do further testing that we'll talk about. But I just try to be really clear that there's no good non-invasive way to test for fungal overgrowth in the GI tract.
I've also heard in terms of the symptom picture, people who have an intolerance to sugars, alcohol, white rice, kind of white food in general, because it just gets absorbed so quickly. Is that something that you see?
So definitely sugar intolerance. And so these patients, had a patient last week where even fruit is a problem for her.
Right.
So if they're telling me, even fruits that are low histamine, they aren't high in fructose, they're just reacting to fruit and sugars in general, honey, maple syrup, refined sugar, whatever, and sometimes starches too.
Right.
That can be a tip off that this might be something that we want to look out for. And we don't want anyone to have to avoid healthy foods in those categories forever. So our goal is not to remove them indefinitely. It's just to kind of explore what might be causing the intolerance.
I guess, can we back up for a second? I guess my first question is, when I have a patient in front of me and I'm thinking there's a chronic IBS, the gas, the bloating, diarrhea, constipation, whatever, when am I going to think to order SIFO? When am I going to think I'm going to go down a SIBO train to work them up?
It's a good question. And I've been thinking about this in my head. Ideally, if, finances weren't an issue, I would probably test people for SIBO, Protozoa, and SIFO all at the start. But most of us are seeing patients the three of us see patients through insurance usually. That's a lot to ask someone to do right off the bat. That being said, I think we could at least present the option of getting the data initially. The other option would be you pick one. So you pick SIBO or SIFO. Right. Usually I'll pick, we'll pick one or the other. If they've already been treated for those things, I'll go to the stool testing for Protozoa. But if they haven't, you pick one and see, the herbs we use for SIBO treatment also often treat SIFO and vice versa. The challenge is we have a lot more research for SIBO where we know we need to look at motility. We know we need to look at other underlying risk factors. We don't have that level of data with SIFO. Mm-hmm. So I have thought about at times, are some of these patients ongoingly symptomatic, not because they didn't have fungal overgrowth and the herbs we gave them didn't work, but because they have a motility issue and we just don't have the research for SIFO. So I think it's worth talking to patients off the bat. How much data do we want? Again, the Candida antibodies and immune complex are covered with insurance. So I'll pretty much always order those. If it's in the picture, we'll just get those. And then you could get your SIBO breath test. And then you could either get the stool test for Protozoa right off the bat, or you could, sometimes I'll do that as like, let's wait, let's treat you for these. Because again, the herbs we use are broad spectrum. Berberine, neem often can work for Protozoa too. So we may be able to save people that. So I just try to have that discussion with them. But I do wonder about, would it be more efficient to just get the breath test, the insurance covered Candida testing, and a parasite Protozoa stool test off the bat?
Let's say somebody comes in and they have truckloads of money and they want to run all these tests, and all three come back, because that's a possibility.
Right.
What's your priority?
I would go after the Protozoa first because I feel like we can eradicate it. Yeah. Sometimes it takes a couple rounds of treatment, but at least we can kind of get that off the table. We'll get to those episodes. We have to make sure they're filtering their water as well, especially if where they live doesn't filter for organisms to the extent that we want them to. And then we're dealing with SIBO and SIFO, and those we can combine treatments that overlap with the herbs. Yep. And we'll already know that we have to be on the lookout for motility issues as part of our treatment plan, and not just treating with herbs and then stopping,
I agree. I agree.
And in terms of SIBO versus SIFO treatment, I've heard a lot of debate over which one to do first for maximum efficacy. What are your thoughts?
So with SIBO, if we can get rifaximin covered, and that's almost all, you guys can confirm this, that's almost always going to be a part of the treatment unless it's hydrogen sulfide, right? So
the antibiotic treatment.
Yeah. So, I mean, we all generally like rifaximin, I think. So if we can get that on board, and then with the herbal treatments, we can overlap with SIFO. So, I've heard some of the GI gastroenterologists who treat these things, they'll often treat SIBO first because they think some of the antibiotics that have to be used, if rifaximin isn't covered, may predispose to fungal overgrowth. Right. So then it would make sense to do it sequentially. But I don't use those other antibiotics for SIBO. You can talk about if either of you do, but if we're just using rifaximin, we're not going to be encouraging fungal overgrowth. Right. So we could use that in combination with either, if we need the Alimed, we could do that. But if we're going to do more herbals as well, I use a lot of Golden Thread Supreme and Malia Supreme, which are the Supreme Nutrition.
So that's neem and coptis,
that's
right?
Neem and coptis, which have efficacy for fungus and yeast. The important thing to think about is the way that I learned this is if a treatment doesn't work with herbs, it doesn't mean we went after the wrong organism. We have to find the right herbal option for that patient. I mean, we have to find the right either antibiotic or botanical option, because people have their body needs different potential interventions. Even if they have yeast, not everyone's going to respond to those same herbals.
Right.
It depends on what species, the sensitivities, which is hard to do as far as lab testing.
How are you monitoring whether people are responding or not? Is it just symptoms?
So
That's a great question.
Yeah, I often do monitor with clinical symptoms. I don't usually retest the Candida antibodies and immune complex, but that could be one thing to consider.
Mm-hmm.
The other thought is there is some coverage for the organic acid testing. It's just always been very confusing for me to figure that out.
Can you explain what I feel like I am lost with organic acid?
It's looking at organic acids, which are breakdown products from different organisms. So they also look at other nutrient pathways, but if we're going to focus on the microbial organic acid test, they have about 9 metabolites that they look at for breakdown products that fungal organisms would be making as part of their metabolism. Arabinose is the one that's been sort of looked at the most, but there's a whole list of them. Mm-hmm. So that would be one way to do an initial test and then use follow-up testing to see if those metabolites resolve, but there's an out-of-pocket cost with that.
Okay, can I just ask a question that I always wonder when we talk about functional tests, with a disclaimer that I love functional tests? Is there any validation? Have they been validated?
Okay, good question. I have not looked into that because I haven't used it as much as I do the insurance. So I took a deep dive into the antibody and immune complex testing because that's mostly what I use. The organic acid testing, I would have to check if there's validation for that. I know they've published case reports where, okay, this person had these elevated metabolites. We gave them an antifungal. These are the symptoms that improved, but I haven't looked at, have there been external studies done on correlation between the positives on that test, response to treatment, or because you'd have to really have an aspiration gastroduodenal aspirate.
So can you explain how, if you were in the conventional world, how would you test?
Right. So really the gold standard is aspiration and culture from the third or fourth portion of the duodenum or the jejunum. And that would have to be done during an upper endoscopy with a GI doctor.
Which is the same as the gold standard for SIBO.
Right.
It's just never done.
Yeah. Right. And we have a pretty good breath test, non-invasive test that we can use for SIBO. So I'm hoping someone will come up with a equivalent sort of test for SIFO, but right now we don't have that. So to really do a validated study for organic acid testing or anything else, we would have to be comparing it to an aspiration, which I don't know any GI doctors in our area that are doing that.
No, I would agree. Okay. And so then you have the potential of working it up using the organic acid. You have the potential of working it up using the Candida, IgG, and immunoglobulins.
IgG, IgA, IgM. IgG was the one with some research showing patients who scored high on the fungus-related disease questionnaire.
What's that questionnaire called?
FIDQ7. Yeah.
Oh, how do you know that, Rebecca?
Shout out to Dr. Megan Taylor.
Okay.
I'm pretty sure she's the one who
I was like, who else knows about this questionnaire?
Yeah,
okay.
I have a dot for you.
Okay, great. So I didn't realize anyone else knew about that. So that questionnaire and IgG elevation and IgG antibodies to Candida did have a correlation in a study that I cite in my class that showed patients who scored high on that test did have elevated IgG antibodies that improved with treatment. As opposed to the IgA and IgM, there has not been validation in that way.
Are we done with, I feel like I'm like, I want to make sure I know how to work this up.
Okay.
So those are the two options. Okay.
I think perhaps what you've been doing as well is if there are symptoms that are persisting in the absence of SIBO, like we either got a negative test or we've already treated it and it's resolved, and people are still having symptoms. That's usually when it's on my radar, just because we don't have as clear-cut of a path to treat it as we might.
Right. I mean, I would say for anyone with IBS or other symptoms that we think might be related that we went over, I don't see a harm in getting the Candida antibodies and immune complex from the start in your initial lab order. That's what I do for.
And the conversation we're having today is about small intestinal fungal overgrowth, not large intestinal fungal overgrowth.
So clinically, I don't really think it matters that much. In research studies, it matters. And for certain disease processes like ulcerative colitis per se, versus if it was other forms of inflammatory bowel disease or IBS, clinically, I don't see a difference in how I would approach it if it's small intestine versus large intestine overgrowth. But the research studies do talk about them separately.
So then shouldn't we also talk about stool testing, finding fungus?
Yes, we should. And here's the problem with stool testing. I found no research on the concentration or yeast per high power field or anything that supports using stool as a diagnostic measure for fungal overgrowth. That being said, I clinically, when we see it on a stool test, I could see that it could be, it does seem to correlate in certain instances with patients who are having fungal overgrowth of the large intestine, or, clinically that their body's having a problem dealing with fungus. But I could not find any research to back that up. So when I've given the class about this, I usually say, with a stool test, the way I find it helpful would be if they did do sensitivities, it might give us some tips on what might be efficacious for that person. But really, all of us should have, most people have yeast in their large intestine. And so we need more data on what concentration would show that was problematic. And my mentors have had very opposite opinions on, Dr. Vincent says if it doesn't show up on a stool culture, he finds that to be more concerning that they have an issue because their immune system is fighting so hard that it's not even showing up. I'm sort of in the middle. It's not diagnostic. Let's use it amongst the clinical picture of everything.
So that is a finding that I often find on some of the older, not the PCR based tests, where when you culture it out, it'll be nothing comes up, but then on microscopy, they show yeast abundant or yeast, high. And so I'm like, I don't even know what to deal with that.
So one of the teachers that I had learned from in medical school had said he thought people who had an issue with fungal overgrowth were secreting something in the stool that was preventing it from culturing. And so again, does that have something to do with these patients that have a genetic susceptibility to fungal overgrowth? What are they secreting? I don't know enough about lab analysis to know, but that was his theory as to why it wasn't culturing.
Can we talk about something that I've heard once or again and again in the holistic world, and I want to know if you have any feelings about it.
Okay.
So one of the things that I hear again and again is one of the functions of yeast within the body is to push detoxification, and especially the detoxification of heavy metals.
Okay, so this theory I've heard as well, and it was that if you have a heavy metal burden from whatever environmental exposure, Candida and yeast species would overgrow to sort of chelate with those metals and prevent them from affecting the body as much. I haven't dug in to see if there's data on that. I would say clinically, I think if someone has something like a heavy metal burden that's suppressing their immune system, it would make sense that they're not keeping normal organisms in check, just like we see with tick-borne infection, Lyme disease, et cetera. Patients may be having a Candida fungal overgrowth as well as SIBO because their motility is not working and they're not keeping normal organisms in check due to some immune suppression.
I will also say that when I did my crazy deep dive about biofilms way back when, one of the things that I found about Candida is it is like when we're talking about the biofilm environment, it is one of the key players to like protect and allow other pathogenic species to work in relation with each other.
Right.
It's like the way I always describe Candida in particular, and I know there's lots of other funguses that we're talking about, but the way that I describe Candida in particular is it's like not a bad guy, but if it's around a lot of bad guys, it's going to maintain the environment of the bad guy.
Right.
Like in the neighborhood, it's like the guy that rolls with all of the other bad guys. And I think that's what we see in chronically immunosuppressed population, like the HIV population, like the cancer population. We see fungal overgrowths in deep, deep, deep pathology because it's so good at Jill Krista, she has a phenomenal talks on mold, but she breaks it down when she's like, it is mold's job to decompose you.
Right.
Like literally it's amazing because in the forest, that's what mushrooms do. That's what fungus does. They break down the wood. They break down the earth to recycle it. And when you have an abundance of fungus in you, the fungus is breaking you down. I mean, it's kind of amazing.
Right. So it's about the balance, and so everyone has some, and it's just a matter of getting it back to a balanced state where the actual concentration is where we want it to be and where the immune system interaction with it is beneficial and not like an allergic hypersensitivity response to those organisms.
And you think you hit hypersensitivity and that's when you hit MCAS and all of those things?
I think you can have MCAS histamine responses with overgrowth or hypersensitivity. Dr. Theo Harides, who's one of the MCAS researchers, he showed that when fungal organisms hit mast cells, it causes degranulation. So if there's an overgrowth, that could potentially lead to increased mast cell degranulation, increased histamine issues. But also, if you have any kind of allergic hypersensitivity response to allergies, whether that's food, environmental, or you've become allergic in some way to your microbiome population, whether that's yeast or other organisms, that also can lead to inflammatory response and likely increased mast cell activity.
I am going to say that the other place where I feel like I think about SIBO a lot is chronic abdominal pain.
You mean SIFO?
Sorry,
or
SIFO.
Okay.
It was with chronic abdominal pain. Like I feel like there's something with the fungus breaking down the mucin layer, where if people are stuck in a chronic, like unclear abdominal pain,
Right.
fungus is also on the top of my list. Do you have any other places you think about fungus?
For me, it's a lot of diet. Like if people do fine with FODMAPs, but they can't do white rice, like every time they eat white rice, they get totally knocked out, which is kind of tricky with the MCAS picture too.
Right.
Especially with like alcohol and fruits like that. But if it sure seems like SIBO, but they don't have SIBO, that's usually what I consider it. On the topic of the stool testing, and I know this is controversial,
right?
If somebody comes back positive, are you only considering large intestine overgrowth there, or if in the context of bloating and small intestine symptoms, are you looking at treating both?
So I don't think it really matters because I treat it basically the same way. Although it could matter in sort of your post-treatment healing phase if you're targeting small intestine or large intestine. But I would say yes. I think of it more of like, is this person's body having trouble keeping fungal organisms in check, whether it's in the small intestine or the large intestine, or wherever in the body, recurrent GU infections, etc. So it doesn't matter so much in my acute treatment phase, but I could see where it would make a difference in whether we're trying to heal the small intestine or large intestine afterwards.
Okay, let's just do a wrap up on SIFO part 1.
Okay.
What do you want to do the wrap up, or do you want me to do it? Because I'm pretty excited about it. I think I learned a lot, Ami. Thank you so much. Okay, so this is what I learned. I learned that when you're looking at a chronic digestive picture, SIFO needs to be in your differential, just like SIBO. It's significantly more difficult to diagnose. We can theoretically somewhat utilize the organic acid testing, especially the microbiology one. But again, we all have questions about validation, but it seems like there's at least clinical write-ups that show efficacy. We also can rely on those insurance-covered blood markers like Candida IgG in particular and Candida immune complex, which somebody wrote a study somewhere that Quest cited that says that shows intestinal candidiasis.
Right.
And when we're talking about treatment, it seems like you want to prioritize protozoa first and then focus on bacterial and fungal overgrowth, either at the same time or sequentially, depending on if you're going to be using antibiotics.
That sounds...
Did I miss anything?
Great.
I think that was great. A big takeaway for me was the interaction with MCAS, and that if somebody comes in that we know or really suspect they have MCAS, rather than just jumping to SIBO, I may be more thinking of SIFO just because of the interaction.
Right. And we can talk next time about the studies that show increased allergic issues in animal studies if people are interested in that.
Yes.
Whoa. Thank you. That was awesome.
Okay.
Thank you. Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the Turd Nerd word.